Head anatomy and conditions. The skull is very important and protects some vital structures, including the brain and the spinal cord. The skull is composed of 22 bones. While all the bones appear to be one single bone, they are actually different bones that are all sutures, which are immovable joints, with the single exception of the mandible, more commonly known as the lower jaw. The occipital bone in the back of the skull, it is the red bone in the picture, is the strongest. The temporal bone on either side of the head, it is the light purple bone in the picture, is the weakest. The scalp is composed of 3 layers. Skin is the outermost layer, and then there is the subcutaneous connective tissue, and finally the pericranium. There are 4 major regions in the brain. The cerebral hemisphere is responsible for interpreting sensory impulses and controlling motor activities. The diencephalon acts as a sensory information station and is responsible for regulating hunger, thirst, and body temperature. The cerebellum is responsible for regulating balance and coordination. The brainstem, which is made up of several different areas, including the midbrain, the pons, and the medulla oblongata, is responsible for controlling reflexes, as well as breathing, heart rate, and blood pressure regulation. The meninges are the 3 membranes that envelop the brain and spinal cord. The meninges in order from the inner to outermost layer are the pia mater, arachnoid mater, and the dura mater, or the acronym PAD. Cerebral spinal fluid is located in the subarachnoid space between the arachnoid mater and the pia mater. The primary function of the meninges is to protect the central nervous system. The pia mater, or Latin for tender mother, is very delicate membrane. It is the meningeal envelope that firmly adheres to the surface of the brain and the spinal cord, following all of the brain's contours. It is a very thin membrane composed of fibrous tissue covered on its outer surface by a sheet of flat cells thought to be impermeable to fluid. The pia mater is pierced by blood vessels to the brain and the spinal cord, and its capillaries nourish the brain. The middle element of the meninges is the arachnoid mater, so named because of its spider web-like appearance. It cushions the central nervous system. This thin transparent membrane is composed of fibrous tissue and, like the pia mater, is covered by flat cells also thought to be impermeable to fluid. The dura mater, or Latin for tough mother, is a thick, durable membrane closest to the skull and the vertebrae. The dura mater contains larger blood vessels that split into capillaries in the pia mater. It is composed of dense fibrous tissue, and its inner surface is covered by flattened cells like those present on the surfaces of the pia mater and the arachnoid mater. The dura mater is a sac that envelops the arachnoid mater and surrounds and supports the large dural sinuses carrying blood from the brain toward the heart. Cerebral spinal fluid, or CSF, is clear, colorless body fluid that's found in the brain and the spine. It is produced in the choroid plexus of the ventricles of the brain. It acts to cushion or buffer the brain's cortex, providing basic mechanical and immunological protection to the brain inside the skull. The CSF also serves a vital function in cerebral autoregulation of cerebral blood flow. The CSF occupies the subarachnoid space, or the space between the arachnoid mater and the pia mater, and the ventricular system around and inside the brain and spinal cord. There are 4 common types of skull fractures. It takes a lot of force to fracture the skull. A linear fracture, or the orange fracture in the picture on the left, is a fracture which goes straight across the cranial bone. This is the most common and is a result of a direct hit, usually with an object moving at a very high velocity. A depressed fracture, the green fracture in the picture on the left, occurs when the bone is driven inward towards the brain tissue. A comminuted fracture, or the red fracture in the picture on the left, occurs when the bone fragment during impact. This is usually due to a very high velocity object striking the skull. A basilar skull fracture, or the blue fracture in the picture on the left, occurs at the base of the skull. They are more common in sporting activities and within the military population as a result of high impact blasts. The most common signs and symptoms of skull fractures are severe headache and nausea, unequal pupils, raccoon eyes, which are two black eyes, battle sign, which is bruising behind the ear at the base of the skull and is a key feature of a basilar skull fracture, and a positive halo sign. The halo test is accomplished by collecting fluid from either the nose or the ears on a tissue and letting the tissue dry. We're looking for a yellowish ring to form around the area of the fluid. The yellow ring is actually cerebral spinal fluid that separates from the other mucus, creating a halo effect. The best management for potential skull fractures or an obvious skull fracture is to get them to emergency care help as soon as possible. Diffuse cerebral conditions include concussion, post-traumatic headache, post-concussion syndrome, and second impact syndrome. A concussion is also known as a mild traumatic brain injury, or MTBI, and the two terms are used interchangeably within the literature. There are approximately 1.6 to 3.8 million reported cases of concussion annually in the United States. Many researchers and medical workers have suggested this actual number of concussions would double or triple if all concussions were actually reported. Approximately 50% of all concussions go unreported. 15% of concussed athletes will incur a second injury during the same season. Unfortunately, with the increased attention concussions are getting, athletes are getting better and better at hiding symptoms from healthcare workers. There is more information available, and sometimes young athletes, and even professional athletes, do not want to be taken out of a game. A concussion may be caused by a direct blow to the head, face, neck, or elsewhere on the body. A coup injury is from the primary impact and happens at the point of contact. A contra-coup injury is from a secondary impact and occurs on the opposite side of the head. Both coup and contra-coup injuries can result in concussion. The only difference is the area of the brain that ends up bruised. Concussions can be very confusing as they present in different ways for different people. Also, the definition of concussion is varied among the research. The University Interscholastic League of Texas, which governs pretty much all public schools in the state of Texas regarding academic and athletic pursuits, has defined concussion as a complex pathophysiological process affecting the brain caused by a traumatic physical force or impact to the head or body, which may include temporary or prolonged altered brain function, resulting in physical, cognitive, or emotional symptoms or altered sleep patterns, and involves loss of consciousness. Other researchers have said concussion is a transient neurological dysfunction resulting from a biomechanical force. Or a concussion is a blow to the head causing an alteration in the mental status and one or more of the following symptoms: headache, nausea, vomiting, dizziness or balance problems, fatigue, difficulty sleeping, drowsiness, sensitivity to light or noise, blurred vision, memory difficulty, and difficulty concentrating. The National Athletic Trainers Association has provided the following definition. A cerebral concussion is classified as a mild traumatic brain injury and often affects athletes in both helmeted and non-helmeted sports. Not very specific. Concussion guidelines are rapidly changing in the field. Just a few years ago, athletes were expected to shake it off and continue to play after suffering a concussion or a ding. Today, we now know that it's unsafe for athletes to return to play the same day they have suffered a concussion, and it is recommended that every athlete not return to play until they've been cleared by the appropriate medical professionals. Sports-related concussion, or SRC, is a common injury in the recreational and organized sport athlete. Over the past 30 years, there has been a significant progress in our scientific understanding of SRC, which in turn has driven the development of clinical guidelines for diagnosis, assessment, and management. In addition to a growing need for knowledgeable healthcare professionals to provide evidence-based care for athletes with sports-related concussion, media attention and legislation have created awareness and, in some cases, fear about many issues and unknowns surrounding sports-related concussion. The American Medical Society for Sports Medicine formed a writing group to review the existing literature on sports-related concussion. They have updated their previous position statement to address current evidence and knowledge gaps in regard to sports-related concussions. As of January 2019, the American Medical Society for Sports Medicine position statement on concussion in sports defines concussion as a traumatically induced transient disturbance of brain function that involves a complex pathophysiological process. Concussion is a subset of mild traumatic brain injury, which is classified based on acute injury characteristics at the less severe end of the brain injury spectrum. The clinical signs and symptoms of concussion cannot otherwise be explained by drug, alcohol, medication use, or other injuries, such as cervical injuries or peripheral vestibular dysfunction, or other comorbidities, such as psychological or medical conditions. Concussions used to be graded on a 3-level scale. Now they are more black and white in their diagnosis. You either have a concussion or you do not. It is kind of like being pregnant. You are either pregnant or you are not pregnant. There is no such thing as being kind of pregnant or kind of concussed. Although it may be difficult to agree on the definition of concussion, there are some pretty scary facts that have been attributed to traumatic brain injuries. Traumatic brain injury facts. 52,000 traumatic brain injuries result in death each year. 1.4 million traumatic brain injuries require emergency visits annually. The cost of caring for traumatic brain injuries is approximately $765 billion every year. Children, teenagers, and the elderly are most likely to suffer from traumatic brain injuries. Males are more likely to receive a TBI than are females, although the research has varied on this statistic. Some researchers have suggested that females are more likely to sustain a concussion because of decreased neck strength. Others have suggested that the increase in female concussion prevalence might be due to better reporting and have even suggested more honesty in the reporting of symptoms by female athletes than their male counterparts. The most common long-term side effect from traumatic brain injury is emotional dysfunction. Approximately 60% of people who have suffered from a traumatic brain injury have shown signs of emotional dysfunction. Previous TBI also increases the risk of epilepsy, Alzheimer's disease, and Parkinson's disease. The primary elements of the pathophysiological cascade following concussive brain injury include abrupt neuronal depolarization, release of excitatory neurotransmitters, ionic shifts, changes in glucose metabolism, altered cerebral blood flow, and impaired axonal function. Immediately after biomechanical injury to the brain, abrupt indiscriminate releases of neurotransmitters and unchecked ionic fluxes occur. The binding of excitatory transmitters, such as glutamate, to the N-methyl-D-aspartate or NMDA receptor leads to further neuronal depolarization with the efflux of potassium and influx of calcium. These ionic shifts lead to acute and subacute changes in cellular physiology. Acutely, in the effort to restore the neuronal membrane potential, the sodium-potassium pump works overtime. The sodium-potassium pump requires an increased amount of ATP, triggering a dramatic jump in glucose metabolism. This hypermetabolism occurs in the setting of diminished cerebral blood flow, and the disparity between the glucose supply and the demand triggers a cellular energy crisis. This resulting energy crisis is likely the mechanism for post-concussion vulnerability, making the brain less able to respond adequately to secondary injury and potentially leading to longer-lasting deficits. Following the initial period of accelerated glucose utilization, the concussed brain goes into a period of depressed metabolism. Persistent increases in calcium may impair mitochondrial oxidative metabolism and worsen the energy crisis. Unchecked calcium accumulation can also directly activate pathways leading to cell death. Intra-axonal calcium flux has been shown to disrupt neurofilaments and microtubules, impairing post-traumatic neural connectivity. While the time course of these changes is well understood in experimental animal models, it is only beginning to be characterized following human concussion. Concussion is defined as any transient neurological dysfunction resulting from a biomechanical force. Loss of consciousness was a traditional hallmark of concussion, but is not required to make a diagnosis. Other symptoms include confusion, disorientation, unsteadiness, dizziness, headache, and visual disturbances. Headache is the most common sign or symptom that is noted after concussion. Diagnosing a concussion is not an easy matter. The difficult issue with diagnosing an athlete with concussion is relying on the athlete to provide you with the most accurate information. Most of these signs and symptoms are difficult for the clinician to see, and therefore we must rely on our athlete to be truthful in their reporting. For a long time, changes in levels of consciousness were used to make concussion diagnosis and even to grade the severity of the concussion. Newest research has gone away from this grading system and has simplified the classification. You either have a concussion or you don't. 90% of most diagnosed concussions do not involve a loss of consciousness. Changes in the level of consciousness can be assessed by using the AVPU scale. We first check alertness by asking the person questions. If the person responds verbally, then we know that they are conscious. If they do not respond to verbal stimuli, then we check painful stimuli. The best way to do this is by performing a sternal rub, in which the knuckles of the fist are rubbed on the sternum. This is very uncomfortable, and a person who is unconscious will not move, but a person who is conscious will typically try to get away from the stimuli. If the person does not respond to the painful stimuli, then we determine that they are unconscious. Anterior grade amnesia is the loss of the ability to create new memories after the event that caused the amnesia. This leads to particular or complete inability to recall the recent events, while long-term memories from before the event remain intact. Retrograde amnesia is a loss of memory or access to events which occurred or information which was learned before the injury or onset of disease. Other symptoms include blurred vision, dizziness, drowsiness, excessive sleep, fatigue, headache, irritability or personality changes, nausea, nervousness, poor balance or coordination, ringing in the ears, also called tinnitus, sensitivity to noise or sensitivity to light, also called photophobia, among other symptoms. Concussion symptoms can be divided into 4 categories. Cognitive symptoms of concussion include feeling mentally foggy, feeling slowed down, difficulty concentrating, difficulty remembering, forgetfulness of recent information or conversation, confusion about recent events, or answering questions slowly and repeating questions. Physical symptoms of concussion include headache, nausea, vomiting, balance problems, dizziness, visual problems, fatigue, sensitivity to light, sensitivity to noise, numbness or tingling, and dazed or stunned appearance. Emotional symptoms of concussion include irritability, sadness, being more emotional than usual, and nervousness. Sleep symptoms regarding concussion include drowsiness, sleeping less than usual, sleeping more than usual, and having trouble falling asleep. Some of the most current research is examining the different genders and the different sport athletes and their tendency to have different classifications of symptoms for concussion. The recommended progression for concussion return to play protocol. Please realize that nearly all of the 50 United States have concussion legislation, and within those documents, they may regulate how quickly an athlete might be returned to sports participation. In high school athletes, the earliest the return to play protocol can be initiated is 1 week after a concussion diagnosis. In order to start the return to play protocol, the athlete must be asymptomatic, meaning they are not experiencing any concussion symptoms. If an athlete is asymptomatic, then they may begin an exercise progression, starting with 20 minutes of light aerobic exercise, like walking or riding on the stationary bike. If any symptoms reappear, the progression is finished and we start back at square one the next day. If no symptoms appear, the progression can continue to sport-specific skills, like skating and hockey or running and soccer. Non-contact drills follow, full contact drills after medical clearance, and then finally full participation. Most concussions and other mild traumatic brain injuries should completely resolve within 1 to 6 weeks. Some people, however, experience post-concussion syndrome. Post-concussion syndrome can include physical, cognitive, and emotional problems, including headache, dizziness, difficulty concentrating or completing tasks, irritability, and the sense that you just don't feel like yourself. All of these symptoms can make daily life more difficult, both in personal relationships and at work or school. Over time, and especially with treatment, these symptoms do tend to get better. The long-term effects of concussion are rare. Moderate to severe traumatic brain injury can cause symptoms similar to a concussion, but individuals with these TBIs often experience more severe problems with attention and short-term memory, have difficulty performing daily tasks, and report feeling slower overall. Additional research has suggested that other long-term brain changes may occur. Chronic traumatic encephalopathy is a progressive degenerative disease of the brain found in athletes and others with a history of repetitive brain trauma, including somatic concussions as well as asymptomatic subconcussive hits to the head. This disease was previously called dementia pugilistica, or punch drunk, and was initially found with those with a history of boxing. Although long known to occur in boxers, it wasn't discovered in football players until 2005. Researchers at Boston University recently confirmed 50 cases of CTE in former football players, including 33 who played in the NFL. The study of CTE in football is still in its infancy. The prevalence of this disease has not been established. It cannot be diagnosed in living people, only by examining brains that are removed during autopsy. Depression and substance abuse and suicide are also factors that are found in post-concussion syndrome. One sad example of this was Junior Seau. Junior Seau committed suicide by shooting himself in the chest at age 43, following what his family reported was erratic behavior. Autopsy found that Seau's brain had tested positive for chronic traumatic encephalopathy, a neurodegenerative disease which can lead to dementia, memory loss, and depression. Chronic neurological impairments are also possible. More than 4,000 former football players are suing the NFL in a federal court, alleging that the league ignored and denied the link between football and brain injury, even after CTE was discovered in former players. Currently, there is at least one major lawsuit against every professional sports organization concerning concussion. Subconcussive impacts are impacts or trauma to the head which does not manifest with the symptoms at the time of the impact. Some people have wanted to outlaw heading in soccer for its potential to cause subconcussive impacts. However, research has found that intentional heading is not associated with concussion. In biomechanical laboratories, they have verified that the linear and angular acceleration resulting from heading are well below those that cause mild traumatic brain injury. However, long-term practice of heading could be detrimental effects on the functioning of the brain. With new research coming out at all times, it's difficult to keep up. This comic kind of sums up a lot of people's old opinions on concussion. These two guys are sitting on a bench. One of them asks, "Do you remember the good old days when we used to play sports and we never worried if we got a concussion?" The second guy thinks for a bit and answers, "No." As healthcare providers, it's our job to be alert to concussions. There are too many negative consequences to stand idly by and let athletes continue to take risks with their futures. Athletes who return early from concussion protocol could be at risk for second impact syndrome. Second impact syndrome is a rare but catastrophic brain injury in which the athlete who has suffered from a concussion incurs further brain trauma before the symptoms associated with the initial concussion have been cleared. About 50% of athletes die after suffering second impact syndrome, and the rest suffer lifelong impairments. Second impact syndrome can only occur when two head impacts occur, one right after another, in a short period of time. Since the brain is not fully healed from the first injury, it's very prone to being hurt and damaged again. Diffuse cerebral swelling, brain herniation, and death can occur. The pressure in the brain can increase rapidly, resulting in brain death. Many people who have had head injury think that their symptoms go away before they actually do. It can take up to 6 to 18 months before your brain can be fully healed from a concussion. It is important to report your head injury as soon as possible and not to return to sports until you are approved by your doctor. Second impact syndrome is a rare injury which occurs most frequently in younger children and adolescents. They're typically under the age of 25. In a 13-year period from 1980 to 1993, only 35 American football-related cases of secondary impact syndrome were recorded, but of these, only 17 were confirmed by necropsy, surgery, or MRI. When an athlete suffers from a concussion, they will experience several symptoms following the concussion. It can take the athletes minutes, hours, weeks, or months to get over these symptoms and to be able to play again. If the athlete returns to play before any of these symptoms are cleared and gets another hit on the head, they have the possibility of getting second impact syndrome. Since the brain is already not fully healed, the athlete doesn't even need a hit on the head to set it off. They can get hit in the chest or the back and it can jerk the head and cause second impact syndrome. When they get hit the second time, the brain is very vulnerable and is not fully healed, so the second initial hit can cause massive swelling to the brain very rapidly. Once the athlete gets hit, they can seem fine and remain alert and still walk off the field or court. After approximately 15 seconds to a minute after the hit, they start to seem dazed or out of it. Once the swelling of the brain has started, the athlete will collapse but will still be conscious. Their eyes will rapidly dilate and move back and forth, and eventually they will lose consciousness and stop breathing. The brain is contained in the rigid bone of the skull. The swelling causes a lot of pressure on the brain, which in some cases cause the brain to squeeze through little holes in the skull. When the brain squeezes through these little holes within the brain, it's called a herniation. Herniation leads to decreased blood flow to the brain, which eventually causes the brain to die if not stopped in time. Symptoms of second impact syndrome are very similar to severe brain injuries, which makes it hard to detect and sometimes can even go undetected. All symptoms can happen in seconds, hours, weeks, and months after the second head injury. Please make sure to watch the YouTube video on our Blackboard site concerning second impact syndrome. Focal cerebral conditions include epidural hematomas, subdural hematomas, and intracranial hematomas. An epidural hematoma is very rare in sports and results from an arterial tear in which causes bleeding between the skull and the dura mater. The accumulation of blood can occur extremely quickly, within minutes to hours of the injury. Most often these are seen in car accidents, and around 15 to 20% of epidural hematomas are fatal. The signs and symptoms of an epidural hematoma include the initial loss of consciousness, followed by a lucid interval, and then gradual deterioration in mental health status within 10 to 20 minutes. Other signs and symptoms include headache, nausea, drowsiness, ipsilateral pupil dilation or same-side pupil dilation, decreased level of consciousness, and contralateral or opposite side weakness. Epidural hematomas should be managed quickly by referring the person to an emergency medical service. Typical treatment will require surgical decompression or removal of the cranial bones. CT scans and MRIs can measure the amount of bleeding. A subdural hematoma is nearly 3 times more likely to occur than an epidural hematoma. Blood gathers between the dura mater and the brain, usually resulting in tears from bridging veins which cross the subdural space. Subdural hematomas may cause an increase in intracranial pressure, which can cause compression of and damage to delicate brain tissue. Subdural hematomas are often life-threatening when they're acute. Subdural hematomas are the leading cause of catastrophic death in athletes. Because it is a venous rupture, the symptoms are much slower to develop and may take days or weeks to appear. Symptoms of a subdural hemorrhage have a slower onset than those of epidermal hemorrhages. Because of the lower pressure, veins bleed more slowly than the arteries. Therefore, the signs and symptoms may show up minutes, if not immediately, but can be delayed by as much as 2 weeks. If the bleed is large enough to put pressure on the brain, signs of intracranial pressure or damage to parts of the brain will be present. If someone is suspected of having a subdural hematoma, please refer them to emergency medical services immediately. Intracranial hemorrhage occurs when the blood vessels rupture within your brain or between the skull and your brain. A collection of blood or hematoma compresses the brain tissue. An intracranial hematoma may occur because of fluid that surrounds your brain cannot absorb the force of a sudden blow or quick stop. Your brain may slide forcefully against the inner wall of your skull and become bruised. Although some head injuries, such as the ones that cause a brief lapse of consciousness, can be minor, an intracranial hematoma is potentially life-threatening and requires immediate treatment. An intracranial hematoma often, but not always, requires surgery to remove the blood. Signs and symptoms of an intracranial hematoma may be evident right after the blow to the head, or they may take several weeks or longer to appear. You may seem fine after a head injury, with a period called lucid interval. However, with time, pressure on the brain increases, producing some or all of the following signs and symptoms: increase in headache, vomiting, drowsiness and progressive loss of consciousness, dizziness, confusion, unequal pupil size, slurred speech, increase in blood pressure, and as more blood fills your brain or the narrow spaces between your brain and skull, other signs and symptoms may become more apparent, such as lethargy, seizures, and unconsciousness. The management for an intracranial hematoma is the same as it was for both the epidural and subdermal hematomas. Here's a picture of an epidermal hematoma on the left, a subdural hematoma in the center, and the intracranial hematoma on the right. When we are assessing cranial conditions in our athletes, we need to remember to check vital signs. Vital signs are the measurements of the body's most basic functions. The four main vital signs routinely monitored by medical professionals and healthcare providers include the following: body temperature, pulse rate, respiration rate or rate of breathing, and blood pressure. We should also assess the history of the individual and perform mental status testing. Ask our individuals to identify orientation, like do you know where you are at? Concentration, can you please remember these three words? Blue, ball, boy. I will ask you these words a little later, and you will need to repeat them back to me. Look at behavior symptoms. It is better if you have had previous interaction with your individual prior to injury so you can determine what is normal versus abnormal behavior in an individual. Then assessing for loss of consciousness. All of these mental status testing protocols are commonly found on either a SAC, Standard Assessment for Concussion, or a SCAT, a Standard Concussion Assessment Test. We are also looking for a halo test, raccoon eyes, or battle sign, which could all signify a pretty significant cranial injury, including fracture. Also, palpation and neurological examination should be performed, including testing the reflexes, strength, coordination, and balance. There are several assessment batteries that we can use. Some examples would be IMPACT, which is a computer test, the SAC test, the Standard Assessment of Concussion, and the SCAT test, the Standard Concussion Assessment Test. They all involve cognitive testing and balance. The sensitivity of a comprehensive battery, including a graded symptom checklist, computerized neuropsychological test, and a balance test, reached 94%. It is important when we're doing concussion assessment that we don't rely on just one assessment. Rather, we need to look at multiple assessments to check the individual for health and safety. A copy of the SAC test will be provided on Blackboard, as well as the SCAT-5 document for concussion analysis. If you have any intention of going into coaching, athletic training, physical therapy, chiropractics, or any other allied healthcare profession, it is important that you are at least familiar with this type of form. Oh, and before I forget, when you're asking your athletes about their ability to concentrate, make sure you ask them to repeat those words that you gave them. Again, can you remember what they were? That's right, blue, ball, and boy.